How to monitor blood glucose in hospitalized patients and what specific blood sugar targets we aim to achieve is the topic of our video today. This is the second video of the inpatient diabetes management series, and if you missed the first video, the link to that video is provided below. Also, if you would like to receive a PDF summary of this video and future videos on our channel, sign up using the link provided below as well. And let's dive right in. Blood glucose monitoring, also referred to as GlucoCheck or AccuChecks, both by the way are brands for glucose monitoring machines, can be performed in two ways. First, using a capillary blood sample obtained via finger sticks, and second, using a venous blood sample used for routine blood work. Blood sugar value is a part of the CMP or BMP complete metabolic panel or basic metabolic panels. Now, while both methods are accurate, it is not practical or cost effective to send for a BMP or CMP every time we need to check for blood sugar levels. It's important to note that also the machine used in finger sticks have upper and lower limits for readings. If the blood sugar levels falls below or above these cutoffs, the machine will display a message instead of an absolute value. In such a case, we may need to rely on a BMP or CMP to determine the exact blood sugar value. Give me your full attention now. One common mistake that we frequently encounter is collecting a blood sample from a line where a dextrose containing solutions, TPN total parenteral nutrition, PPN peripheral parenteral nutrition is being administered. The glucose concentration in the blood drawn directly from these lines can be deceptively high. Therefore, if there is an abnormally high blood sugar readings on a BMP or CMP, it should be confirmed with a finger stick blood sugar measurement before doing any or providing any treatment. Let me give you a quick story. I still vividly remember my experience as an intern when one of my patients was receiving TPN and the nurse reported a critical blood sugar value of 1000 milligram per deciliter over the phone to me. Being on my first inpatient rotation, I was literally stunned and unsure of what to do. So I told the nurse eventually to administer 10 units of IV regular insulin. When I got to the floor, I discovered that one of my attendings had stopped the order and asked for a finger stick blood sugar readings to be taken instead. And guess what? It was only 180 milligram per deciliter. It turned out that the nurse had reported a blood sugar value from a BMP that was drawn directly from the PICC line where TPN was being infused. This experience taught me a valuable but potentially dangerous lesson. The same applies to checking potassium, magnesium, or phosphorus levels from a line where a potassium, magnesium, or phosphorus infusions are being administered. Now, how often should we monitor blood sugar in hospitalized patients? We perform AccuCheck or blood sugar checks Q1 hour or every 1 hour in the following conditions. Patients on insulin drips. These patients should have their blood sugar checked every hour until they are off the insulin drip. Hypoglycemic patients. These patients should get hourly blood sugar checks as well until their hypoglycemia is resolved and no further treatment is required. Patients with severe hyperglycemia but without DKA or non-ketotic hyperesmolar hyperglycemia. These patients likely will need insulin drip. Alternatively, we can order an hourly correction sliding scale which requires hourly blood sugar checks. Of course, if the hourly checks are not possible, as only ICU and step down units can do that in most hospitals, the Q2 or every 2 hours correction sliding scale is acceptable in such case. Now, if the patient is NPO, on tube feeds, or on TPN, blood sugar checks should be performed every 4 to 6 hours. If the patient is eating, then blood sugar checks should be performed before meals and at bedtime, or what we call AC means before meals, HS means bedtime. In some patients, an additional 3 a.m. or 5 a.m. blood sugar check can be performed if early morning hypoglycemia is a concern. Now, probably you have heard about what we call continuous glucose monitoring, which is increasingly used in hospitalized patients. Basically, it means measuring glucose levels 24 hours a day by wearing a special device. But a recent trial showed that mean daily glucose did not differ between participants randomly assigned to the continuous glucose monitoring and those who underwent conventional monitoring with a finger stick and glucometer. Although the continuous glucose monitoring led to a small reduction in hypoglycemia reoccurrences. So most hospitals still use the finger sticks. Let's move on and talk about the specific blood sugar targets we aim to achieve. In general, the goal is to avoid hypoglycemia and serious hyperglycemia. So first, let me run quickly through the current recommendations. Critically ill patients, the target for these patients is having their blood sugar between 140 and 180, and this frequently requires insulin drip to achieve that. On the other hand, non-critically ill patients, their target blood sugar or pre-meal blood sugar should be less than 140, while random blood sugar target of less than 180. And third, post-acute MI or myocardial infarction patients, their random blood sugar should be less than 180. Now, in practice, if you can keep most, not necessarily all, of blood sugar values to fall within the 140 to 180 targets, then you did a great job. Don't rush to make changes if a few sporadic values were slightly above or below the targets. Of course, exceptions are always there. I am usually very liberal with frail, very elderly patients, those with a terminal disease, or hospice patients. Also, I don't pay attention to these targets while actively treating hypoglycemia. So remember the target 140 and 180 and you should be fine. Let me finish by going over some real-life clinical examples. Of course, while on insulin drip, blood sugar should be checked every hour. While on insulin drip, please keep the blood sugar checks every 1 hour and avoid any temptation to reduce the frequency. There are two options here. One approach is to order AccuCheck or GlucoCheck every 2 hours for a total of 3 or 4 times before switching to the ACHS if blood sugar remains under control. Another approach is to switch directly from the Q1 hour to ACHS. Both methods can be appropriate, and it's important to use your clinical judgment to decide which approach to take. Without any doubt, the patient blood sugar should be checked every hour while being actively treated for hypoglycemia. It's wise here at this point to give the patient a trial of the D10 solution, but I will keep checking his blood sugar every hour for 3 to 4 more times to make sure hypoglycemia doesn't bounce back. Then reduce the frequency to Q2 hours every 2 hours for another 3-4 times, then switch to AC before meals and HS at bedtime if remains stable. Here, in addition to making adjustments to his basal/bolus insulin therapy, which we will discuss later in the course, we need to take care of this critically elevated blood sugar. If you are thinking about starting an insulin drip, I will not say it's a bad idea. It's probably the most effective and fastest way to get blood sugar under control and should be in your mind all the time, but this needs to transfer the patient to the ICU or step-down unit in most hospitals, which will delay the patient's treatment. That's if there is available beds. One of the tricks we use in such a case is to order a correction sliding scale every 2 hours if the patient is on the floor, or every hour if the patient is already in the ICU but you decided not to use the insulin drip. This patient was on the floor, so we order an insulin Lispro correction sliding scale every 2 hours. That means the nurse will give the patient a certain amount of insulin Lispro based on his blood sugar reading every 2 hours. We were able to get the patient's blood sugar to 225 before dinner time. So I discontinued the correction slide scale at the time and left him on the adjusted basal/bolus insulin therapy. Now you may be asking, where did I come up with these numbers? I mean, checking for 3-4 times or twice or 5 times. I simply use my clinical judgment in such a case to decide that. This is easy, and I know you know the answer. Simply switch to gluco checks or AQ checks or blood sugar checks every 4 to 6 hours. This applies to patients who are getting TPN, PPN, or NPO. In the end, if you like this video, give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. How to recognize and treat hypoglycemia is coming next in the course. Thanks for watching.